So when we talk about anatomy of the ear, it's quite simple. To understand the embryology of the ear, you first have to know the anatomy of the ear thoroughly. And the anatomy is, you don't need to be artistic about it, but you do need to know all the parts of the ear, which is little complex unless you know, and then it becomes very easy. So let's start with the helix. The helix is the curve that you see on top, followed by the lobule, which is something we all know. Now the helix has a root, and this is the cartilage of the helix that I'm drawing now. This is the crus of the helix or the root of the helix, and the cartilage ends over here. After the cartilage ends, you have the lobule over here. Now you have to realize that there are two main things, the tragus and the antitragus. So the tragus comes out from the helix over here, and then we'll draw the antitragus later. Now you have, after finishing the helix, you have the antihelix. The antihelix is like this bifurcation that's over here, along with a triangle in the middle. So that it's just this cartilage which has this bifurcation, which is called the antihelix. And from the antihelix, you have the antitragus, which is this chotu projection over here. Both of them join over here. So remember, this is all there is to anatomy of the ear: the helix, the antihelix, the tragus, and the antitragus. After this, you have to know the other parts of the ear. This is the inferior crus, the superior crus, the helical crus. Then you have this is the cymba concha, this is the cavum concha, this is the triangular fossa, and this depression between the helix and the antihelix, this is called the scapha or the scaphoid fossa, which is what gives this curve over here. Okay, now that you know the anatomy, let's go back to the embryology. And if you mark it in order, it comes out to, if you start from the tragus and you mark it in order, it comes to 1. Then the helix will be, the root of the helix will be the 2. The helical rim will be 3. Then the superior crus will be 4. Inferior crus will be 5. And the antitragus or the lobule will be number 6. Here you have something called as the Darwinian tubercle in some people. If somebody asks you, it is a normal congenital aberration, physiological congenital aberration. Okay, now going back to the embryology of this ear structure, the ear framework, you have something called as the hillocks of His, which are derived from two arches, two branchial embryological arches. The first three, as you can see over here, 1, 2, 3, they are from the mandibular arch, and the 4, 5, 6 are from the hyoid arch. So if you go in order, it is nothing, it is just 1, 2, 3, 4, 5, 6. This is all you need to know. And here you have the external auditory meatus, which is over here. So here you have 1, 2, 3, 4, 5, 6, which correspond to the parts of the ear starting from the tragus ending on the lobule. 1, 2, 3, 4, 5, 6. If you know this much of anatomy and embryology, I think that's adequate to write your exam paper. Now continuing with the anatomy, these are the parts of the ear that we've already discussed. The crus of the helix, the helical cartilage and the helical rim. Going on to the lobule, then you have the tragus that comes out from the helix. Then you draw the antihelix, and then you have the antitragus that comes out from the antihelix. Besides this, you just need to know a little bit of the muscles This is if they ask you. Some old timer examiners might like this question. So the intrinsic muscles are the tragal muscle, the I'll draw it in another color. The tragal muscle, the antetragal muscle, the oblique muscle, and the transverse muscle. Um, so the oblique muscle, the transverse muscle, the tragal muscle, the antetragal muscle, these are what you need to remember for the intrinsic muscle. The extrinsic muscles are the superior auricular, the posterior auricular, and the anterior auricular muscles. These are adequate for you to remember for the exams. Uh, let's talk about the embryological deformity classification. The one we're going to be talking about is stanza. Besides this, you also have nagata, which is a more practical thing, but it is, I think Tanzer is the one that's going to be asked in the exams. It's very easy. It starts from 0 to 5. Matlab it starts from lesser to maximum. It starts with anosia or complete absence of the ear. Then you've got a microtia or a small ear, but it may or may not involve uh, atresia of the external auditory meter. So you've got no ear, then you've got a small ear, then you've got hypoplasia of the middle third of the auricle, followed by hypoplasia of the superior third of the auricle, followed by a prominent ear or a larger ear. Now, these terms, cup or lop ear, cryptotia, all of these are just, variations of microtia itself, or of hypoplasia. So remember, you've got anosia, that's complete absence, followed by microtia, that's hypoplasia of the entire ear. Then you've got hypoplasia of the middle third. Then you've got hypoplasia of the upper third, followed by a prominent ear or enlarged ears. So the prominent ear or type 5 of Tanzer's classification, that is one question for you. What they've defined it as is, so the projection of the ear away from the scalp and the mastoid. So it from the scalp it should be about 1.5 to 2 centimeter, and from the mastoid it should be about 2 to 4 mm, 4 to 6 mm, and if it's more than that it's considered to be a prominent ear. So so it also includes reduced definition of the anti-helical fold, that is the scapha. So it is more like this. If this has got definition, this the prominent ear will not have any definition. Along with prominence of the concha, this will be more prominent. This is going to be more prominent, along with prominence of the lobule. So if it has these three, it is defined as a prominent ear. The treatment of prominent ear, there are many given, but the ones you can talk about are the two ones that even I remembered. One is the Mastarde suture, and one is the Farnasis conchomastoid suturing. Um, Both of them, the concept is the same. So to draw it in the exams, Mastarde made an incision posteriorly, and one bite was taken from the, and there was a horizontal mattress suture between the mastoid fascia and the posterior part of the concha, this cartilage, and this was tied up. That is all. That is the Mastarde suture. I will re-show it to you. The Mastarde suture is you make the incision. So what you are doing is you're trying to create you're trying to create this cupping enough. The whole thing is flat, and you're trying to create the cupping. So when you take this part and you fuse it to the mastoid over here. What you're doing is you're taking a horizontal suture from the mastoid fascia and going into the cartilage after scoring the cartilage. That is the Mustarde suture. What Furness did was he postulated that it was due to the aberrant insertion of the transverse auricular muscle. So he has divided the transverse auricular muscle and then he's done the same thing. He has taken multiple stitches between the cartilage and the mastoid fascia. When you're writing about this, if you still feel that the answer requires one or two more things, if it's a long answer, then you can add the complications of the procedure. They can be hematoma, infection, granuloma, irregularity, cartilage infection, etc. So a Stahl's ear deformity is relatively simple. If you've understood the anatomy, it's like cake. So this is the helix and the lobule. This is the helical cartilage, and the problem with the Stahl's ear deformity comes with the antihelix, or the crura of the antihelix to be specific. This is the inferior crus and you have the superior crus. In Stahl's ear deformity you have a third crus or the middle crus. That is a problem with the Stahl's ear. The rest of it is relatively normal. The tragus, the antitragus and the cavum. If you see over here, this is the same deformity that you can see in this ear. This is the inferior crus. This is the inferior crus. That was the superior crus, and you have a third middle crus, which is causing the deformity, which looks like this. Now, the resultant deformity that's caused is flattening of the entire helix, or the helical pad that is flattened. It looks wider, it looks abnormally projected, and you have widening of the scapha here. I told you the scapha is the gap or the fossa between the helix and the antihelix. Here you have widening or flattening of the scapha and you have a superior pole deformity. The treatment is quite logical. You just have to remove the third crus and you have to adjust the cartilage into it. You have to remove this third crus and you have to reconstruct the ear, the helical rim. Again, you might be asked the complications. The complications are the same: hematoma, irregularity, deformity, cartilage infection, chondritis, etc. The last important one we're going to be talking about is cryptotia. Now, cryptotia just means buried ear into the scalp. Now, once the ear gets buried into the scalp, it becomes a superior pole deformity or type 3 Tanzer. Treatment of this is rather simple. It just sounds complicated, but it is actually just very easy. It's just a logical sequence of events. You are first going to, if this is your scalp tissue, this is the mastoid tissue, and this is the ear and the cartilage portion that's buried inside the ear, and this is the portion that's outside. So this is cryptotia, correct? What we need to do is we need to do a removal of this tissue to the outside, that is by releasing the adhesions. How we can do that is by releasing all the adhesions between the scalp tissue and the buried cartilage. After you release the adhesions and bring it outside, so the ear looks like this. After this, you have to reinsert the cartilage into the effaced ear or into the ear that has come out. This ear gets back its cartilage that you do by a cartilage plasty. Then this defect that we have created, this has to be closed by either local tissue rearrangement or by a flap or by a combination of a graft and a flap or by your Z-plasties or by tissue expansion. So if you write the answer, the first point you do is over here you'll have to first do distraction of the superior pole from the scalp and fiber and removal of all the soft tissue, fibrous and muscular adhesions. The second part will be the cartilage plasty, which is reformation of the cartilage of the superior pole. Then you'll have to do local tissue rearrangement of the gap or the defect that has been left behind. How you can do that is by a Z-plasty, by a VY-plasty. The examples can be a local flap and a skin graft or a tissue expansion. That's all you need to know about cryptococcus.